traditionally have relationships with those countries. And I don't know as much, you know, I did speak with people at Boston College. It depends a lot on who has what kind of science and whether there are medical schools and so on and what sort of work goes on. But they seemed, the scientists there seemed sort of intrigued about the questions there of what they might be doing to make particular investments in this area. But it's difficult because for lots of reasons. I mean, for one, there's a lot of pressure. Most healthcare research now is going to involve public-private partnerships because that's the way research is increasingly done. And therefore, it's going to be driven in part by the kind of priorities that drive medical research in this country in general. And I think that Catholic universities have a responsibility, I believe they have a responsibility to weigh carefully those investments. It's not that investment in cancer research is a bad thing, it's a very good thing. But I think we need to look at who's going to make investments. If not us, then who? Who's going to make investments in this kind of research and how do we go about doing that? But it's difficult because there's also a lot of institutional pressure. I know that there is at Notre Dame. There's lots of institutional pressure to increase our research dollars and also to increase technology infrastructure in South Bend. And so we're weighing these sorts of investments that I'm talking about against other priorities that are also, you know, important to institutions like Notre Dame and other Catholic institutions. But again, I would want to come back and argue that that we have a context, we have a particular context available to us in Catholic universities to raise these kinds of questions, and we have a particular obligation to figure out if we have anything to contribute. At the end of the day, we may not. Our own survival may overshadow our abilities, but I think we have a particular obligation to raise those questions here. Because, again, if not here, where?
First of all, thank you for an extraordinarily lucid and informative talk.
You're very welcome.
I would be most tempted to register for a semester just like to take your course.
You're always welcome.
But there were two issues that I'd like you to comment about, and I'll make a suggestion. Take injustice seriously, and religious communities, and perhaps we could expand on that, must participate in the debate. In this country where we seem to have just accepted as a given that the only way is private enterprise, and you were told to go rush into your doctor to get this prescription, which is a horrible abuse of medical access. But I don't think there's enough action by people who have the voice of a larger community. I'm not talking about the radicals and the left, because we don't get anywhere. We talk to the choir over and over again, yeah. But there is a tremendous injustice which we're not recognizing. And religious communities have a place. And there's one other factor. We're now in a world where when there's bird flu, potentially we here in the most favored of nations can become exposed. And yet once the fury is over, the flourish, and completely reside. So what might those of us who care from that solidarity point of view, what can we do?
You know, those are all great questions. Let me make three responses. I mean, one is that one problem that you point to seems to me to be endemic to any discussion about healthcare priorities, whether we're talking about research priorities or we're talking about distributive justice issues within the healthcare system here, which is that it's always easier to speak about sort of equality in the abstract, and it's always easier to talk about what we call the unidentified patient than it is to talk about the identified patient. So you know, most of our great exercises at healthcare rationing have sort of broken down when it's come to applying those principles to ourselves. You know, so we're okay if we're talking about limits on healthcare, you know, that are going to apply to some unnamed population. But when it comes to us, and that runs all the way through, it seems to me that runs all the way through our best efforts within the Catholic Church to talk about healthcare distribution. I don't know if you remember, but the bishops put out, back when the Clinton healthcare plan was being distributed, the bishops put out a document called With Justice for All, and it was principles for fair healthcare distribution, and it talked about rationing and so on. And the very last minute, it was sort of like a plane, you know, they were heading right toward rationing, and then they pulled up at the last minute and they said, well, of course, what we have to talk about here is a two-tiered system. See, so we have to talk about a basic minimum for all and then access above that. Now, there may be very good reasons for a two-tiered system, but the point is that we find it very difficult to talk about equality in healthcare that might require us to give up something that we already have. And so I think dealing with that is just a threshold issue that we all have to deal with. What's happening, I think, that is hopeful, if anything is hopeful in the whole revolution toward managed care, is that no one likes this system. The doctors don't like it, the employers don't like it, the patients don't like it. And so, you know, if you have enough people dissatisfied, then you at least have a context for some conversation. I think the unfortunate thing that happened in managed care is that we had sort of some of the impetus toward a revision, but without any of the moral payoff. So the money's not going back into the system; it's going into the market. So I think that's one problem, and I think the only way you overcome that is by somehow making your broad, unidentified patient faceless. You have to somehow see what this means. And, you know, after my Ugandan student spoke, there was dead silence in my classroom. I thought, now I couldn't pay for this AV any amount of money, because it made a point I would never have been capable of making in there, but it hit home. So I think that's one. Another thing that you're pointing to is the problem of our moral message as a community. And I think right now we're facing two different problems, certainly as an American Catholic Church, but even as a world church. One is that our message, our public human message about human dignity, has become very narrow and focused on just a couple of issues. Whatever we think about the identification of Catholic moral outrage and Catholic moral commitment with abortion, whatever we think of that, or stem cells, it leaves unaddressed the whole world that we've been talking about today. And so we have nothing to say beyond what we want to say about abortion. And so therefore we have very little to say to the issues involving the developing world. Added to that, of course, is that, you know, our moral authority as a church has been wounded in other ways. And so it seems to me we have to pay attention to the ways in which our identity is being self-defined and defined by other people in these very narrow ways. The third thing is that this question of how do you get involved? And, you know, for a long time, ethicists, Christian and Catholic and Jewish ethicists, you know, they wring their hands because, you know, it's very difficult to affect what goes on in the legislative arena. It's very difficult to get your voices heard. Religion gets marginalized in the debates and so on. And that's all true.